Our next speaker is Dr. Lekha Tummalapalli. Lekha is one of Dr. Poe's products, having come through the UCSF system for her nephrology fellowship. She's currently a nephrologist and health services researcher at Weill Cornell Medicine and a research associate at the Rogosin Institute. Her research examines payment and healthcare delivery strategies to achieve high-quality care for patients with kidney disease. Prior to her fellowship at UCSF, Lekha attended Harvard Medical School and completed her internal medicine residency at the Mount Sinai Hospital. She currently serves on the American Society of Nephrology's Quality Committee, where she's active in health policy work, and she's going to talk with us today about the impacts of health policy on some of the disparities that Dr. Poe described. Dr. Tummalapalli.
Thank you, Dr. Silverside, for that introduction. So I'm honored to speak to you all today for this important symposium. As Dr. Saul discussed with us during the last session, there are tremendous disparities in kidney disease, with Black patients having nearly 3 times the incidence of ESRD. But we can see from the American Indian and Alaska Native population that these disparities can be eliminated. In the Indian Health Service, led in large part by Andy Narva, sustained efforts were made to implement a comprehensive diabetes program, resulting in this dramatic narrowing of disparities. So we can make progress. And this is fundamentally an issue of justice, which is one of our 4 principles of bioethics. We must ensure that health outcomes are equitably distributed and that all patients get the care that they deserve. But this is a challenging problem because there's so many treatment milestones to achieve high quality care for chronic kidney disease. We need to first detect it, improve awareness, manage chronic diseases, ensure that everyone is on the appropriate medications, refer to nephrology at the appropriate time, educate patients about options for different modalities of dialysis, and also conservative management, refer to transplant, and ensure early dialysis planning. And unfortunately, evidence shows that there are racial disparities in most of these steps, highlighted here in red. So I'm going to review data on several of these. So notably, there are not racial disparities in CKD awareness. So on the left, we can see data from the Regards cohort showing that CKD awareness was higher in Black participants, which might be partially explained by having a family history or knowing more people affected by kidney disease. And in the Medicare population, there was no racial disparity in physician recognition of CKD in terms of ICD-10 coding. And not pictured here in terms of CKD detection, similarly, there are no racial disparities in albuminuria testing among patients with diabetes to screen for CKD. So while there are no racial disparities in these early stages of CKD, awareness and detection overall are still unacceptably low. But here's where we get to the crux of the problem. Chronic disease management is a massive issue in the United States, with millions of people with hypertension, diabetes, and obesity, which all lead to chronic kidney disease. Not only do Black and Hispanic people have a higher likelihood of having hypertension, but when they do have it, it's more likely to be uncontrolled. So here we can see in this graph data from NHANES showing that Black and Hispanic participants were more likely to have uncontrolled hypertension greater than 140/90. And the same is true for diabetes. Here we can see that neighborhoods where people live are associated with diabetes control. This is data from Amal Trivedi's group showing that Black and Hispanic individuals were more likely to live in neighborhoods with the worst area deprivation index, which is an index capturing census variables of poverty, lack of education, inadequate housing, and unemployment. And living in worse neighborhoods has consequences. Living in neighborhoods with higher deprivation was associated with worse diabetes control. And even if we look at people living in similar neighborhoods, there were still racial disparities within those neighborhoods, with Black patients least likely to have controlled diabetes. And these disparities have complex mechanisms. This is a figure from Dr. Inanya and colleagues showing how structural racism and discrimination affect social determinants of health, impacting housing, food insecurity, education, employment, access to healthcare, and environmental pollution, which have lifestyle implications, including eating a salt-rich and calorie-dense diet, leading to high blood pressure and diabetes. Racism and discrimination have a biological impact as well, increasing allostatic load, altering gene expression and hormones, and increasing sympathetic nervous system activity, all of which have downstream consequences for kidney health. So next, let's talk about evidence-based medications, also termed guideline-directed medical therapy, or GDMT. The past 3 years have been extraordinarily exciting times for CKD therapeutics. We now have new medications to slow CKD progression and prevent ESRD. Both SGLT2 inhibitors and finerenone are FDA approved to treat diabetic kidney disease. And we have other new therapeutics for complications of kidney disease, including potassium binders and HIF-prolyl hydroxylase inhibitors for the treatment of anemia. But access and affordability remain a huge challenge. And we're already seeing racial disparities in uptake of these new medications. Here we can see for adoption of SGLT2 inhibitors, while it is improving, it still remains only at about 10% for patients with CKD. And Black and Asian patients in this data from the Optum data set were less likely to receive SGLT2 inhibitors. So throughout all of this data, we can see that kidney health disparities are not just a matter of individual health behaviors. They exist within the context of broader society. This is the socio-ecological model, which is a conceptual model to understand how individuals fit within their broader environment. To be sure, individual interventions at the patient level are important. We must improve knowledge and awareness of CKD, as well as medication adherence and health behaviors. But these individual behaviors exist within patients' families, friends, and social networks. So we must see how these fit into the interpersonal environment and within the organizational environment, like churches or other social institutions, and the broader community, how these organizations relate to one another. And ultimately within public policy, how federal, state, and local policies influence all of these factors. So that brings us to the title of this talk, Healthcare Policies to Achieve Kidney Health Equity. Healthcare policies can dramatically impact health outcomes. So I'd like to propose 3 policy solutions to improve kidney health. First, to expand Medicaid and insurance coverage. Second, to improve access and affordability of prescription drugs. And third, to design payment models with equity as a central design feature. First, expanding insurance coverage. 30 million Americans are still uninsured. This is data from Mira Harhe and NHANES showing that Black and Hispanic patients with CKD are more likely to be uninsured. With the Affordable Care Act, many states expanded Medicaid in 2014, such that everyone under 138% of the federal poverty line were eligible for Medicaid. And as you'd expect, after Medicaid expansion, people were more likely to establish care with a primary care clinician and go for a routine checkup. So here, this is data from the Behavioral Risk Factor Surveillance System showing that. There are clear benefits of Medicaid expansion for kidney disease outcomes. including lower ESRD incidence, lower mortality after dialysis initiation, and higher preemptive transplant waitlisting. But 12 states have yet to expand Medicaid, pictured here in the dark blue. So we must continue state-level advocacy to expand Medicaid in these remaining states. And Medicaid expansion is only going to get us part of the way there. So other efforts are needed, like expanding state-based insurance exchanges to expand insurance coverage. So next, moving on to prescription drugs. We now have developed these novel life-saving medications, SGLT2 inhibitors. Patients have to have access to them, and they have to be affordable. But in Medicare Part D plans, SGLT2 inhibitors currently cost patients more than $1,000 per year in out-of-pocket costs. And these innovations have the potential to worsen disparities unless we take action. This graph shows the percentage of insurance plans that cover at least one SGLT2 inhibitor without prior authorization or step therapy requirements. So we can see that Medicaid plans were least likely to cover SGLT2 inhibitors without putting up these access barriers. But importantly, in Medicaid plans, once the prior authorizations are approved, copays in Medicaid are quite low. So these drugs are more affordable in Medicaid due to discount requirements. So prescription drug affordability is a very active area right now in policymaking. There are proposals put forth to try to improve prescription drug affordability by gapping out-of-pocket costs in Medicare Part D and imposing penalties if drug prices outpace inflation. So expanding programs like the Part D Senior Savings Program, which provides discounts for insulin, could also be a promising strategy if they also were expanded to provide discounts for SGLT2 inhibitors as well. So lastly, we must ensure that payment models don't worsen disparities. And on the contrary, we must design them to achieve health equity. Notably, the Advancing American Kidney Health initiatives that were announced in 2019 did not even mention health disparities in kidney disease. There are many payment models focused on kidney disease, in part because it's such a costly condition. So all dialysis facilities have to participate in the QIP, and Rogosin was in the first wave of the ESCO program. So we can design these payment models and quality metrics to support achieving health equity. A new payment model, the ESRD treatment choices model, will incorporate a health equity incentive that rewards clinicians and dialysis facilities for increasing home dialysis and transplant waitlisting, specifically in patients that are dual eligible, so low income. So we need more quality metrics that reward clinicians for narrowing health disparities. In closing, there are public policy solutions to many of these challenges. We need every mind in the kidney community on these issues. So stay involved, and thank you all for the work that you are doing at the individual level, with your family, with your organization, with your community, and at the policy level. You are truly making a difference. Thank you.
Thank you, Dr. Tummalapalli. That was a great presentation, and I appreciate your laying down a challenge for all of us to improve the work that we do.